Well, welcome everyone. It's really nice to be here with you today. I'm Michael Redliner. I am serving in the role of the president of the board of the National EMS Quality Alliance, and we are really excited to be one of the partners who's will be working on this great project, this national EMS quality improvement partnership, and with the aim of reducing the use of lights and sirens across the country, something that we think is super important to the safety of ourselves, our EMS colleagues, our patients. And it's just really exciting to be at this point where we're coming together with a great group of EMS agencies and organizations from across the country to join together to really work on a problem that has been shown to really be an issue with the way that we care for our patients in EMS. And I want to thank a lot of people who have participated in the effort so far. I'm not going to name too many names because there's too many people to thank. And really this has been a team effort with many of the premier experts from the field, but more importantly, really a joint effort from the ground level, looking at the problems that we face around lights and sirens. So I would just, if we go to the next, as you see here, the Center for Patient Safety and a number of other organizations have been really supportive in helping this to push through. So I see that John Kramer's on the line here, and that we have leaders from many different organizations. So thanks everyone, and we'll get started. This is our agenda for today. Again, this is going to be a lot of practical work around beginning this effort, and we're gonna kind of go through some of the background about lights and sirens and some of the evidence that drives this project. We're going to be talking about the quality improvement partnership concept overview. Mike Tigman will take us through that, and Joey Grover will take us through the background of lights and sirens and the evidence around that. So and then we're going to take some time to talk about what it takes to be part of this project, and what we think that the basic expectations are around joining with us to do this work. We'll take some questions and answers, then we'll talk about what the next steps are. So why don't I turn it over to Dr. Joey Grover, who is going to be talking through us a bit about the lights and sirens. And again, remember that if you have any comments as we go through, we really want you to send us your comments. You can come off mute and talk, but this is going to be, there should be a lot of back and forth. There should be a lot of interaction. We're here really as partners for all of you to help kind of shape these efforts around doing this improvement project. Next slide.
Thanks so much, Michael. So, yep, you got it, Mike, to the next slide. So, I think one of the first questions a lot of people ask is, for our first involvement in a national performance improvement project, why did we select this topic? And so I have a very brief presentation, all thanks to Dr. Kupas, who I would argue is one of the leaders in this particular topic in terms of educating us about why I'm hopefully going to persuade you that this is a worthy first intervention on a national level. So when we talk about lights and sirens utilization, what I think makes this project unique compared to any other topic you might select is the number of involvement, I would say, in terms of every agency around the country. There is hard to pick a topic that addresses every agency, right? You could have an agency that is 100% treatment for hypoglycemia, right? When we think about the NEMSPA measures, you can have an agency that treats status epilepticus 100%. But the question really becomes, can you find a project that relates to everyone? So in 2015, using the NEMSIS data, we looked at the overall response rates with regards to lights and sirens utilization. So 76% of response in the United States involved lights and sirens. Similarly, almost 23% of transports use lights and sirens. And when you break it down, you can look at geography, you can look at regionalization and suggest there may be patterns in terms of overutilization in some areas. But really, this is a problem that permeates everywhere. And so we're really happy to have a group representative all over the country, which is what you guys are, to hit on this topic. Mike, you want to go to the next slide? And so the next question, of course, if everyone's utilizing lights and sirens to some degree, is it safe? And we hopefully are going to show you that it's not across the board. So this was actually probably one of the most cited studies with regards to ambulance-related crashes. Watanabe et al. In 2018 published in Annals of Emergency Medicine actually looked at this very question. They were trying to establish whether or not you're more likely to be involved in an accident when utilizing lights and sirens. And specifically, they broke it down of any lights and sirens, full lights and sirens, or no lights and sirens. And what you can see is that there is a very obvious trend in the direction of more crashes associated with lights and sirens. And then when you compare response phase versus transport phase, there's clearly an association when it comes to the transport phase of even having a heightened risk with regards to ambulance crashes associated with lights and sirens utilization. You can go to the next slide, Mike. And so when we talk about a comparison, it is very clear the difference between lights and sirens utilization and no lights and sirens utilization when you talk about accidents. And so if we're saying that the practice itself isn't safe, the then question that I think everyone asks ourselves is, should it be utilized all the time and does it provide benefit, right? If we approach this like any other intervention that we perform. You can go to the next slide, Mike. And so the next question, if we already are thinking there's a direction that leans towards unsafe behavior with regards to lights and sirens, the question is, does it provide benefit? So the next question that we usually would want to say is, well, if the intervention is there to reduce time in terms of arrival on scene or transport to the hospital, how much time is saved? So there have been a number of studies actually looking at this very question. And what you find is the range is somewhere between 1 to 3 minutes or somewhere in that interval in terms of response. And so, you know, this is across the board. You can see the communities are representative all over the country. And yes, we would all agree that there are certain communities where there may be a little bit of a higher benefit. So maybe pushing towards that 3 minutes, and other communities where we may be closer to that 1 minute, right? Maybe the difference between a rural and an urban setting. But the question then becomes is, does that 3 minutes make a significant difference for patient outcome? So this is responding to the response factor. You can go to the next slide, Mike. The next question then becomes, if transport is the one that I've just suggested is even more unsafe with regards to ambulance crashes, how much of a time difference does that make? Once again, we look at somewhere around 42 seconds to 3.8 minutes, according to the studies that we cite here below. But once again, a relatively similar comparison with regards to reduction in time. You can go to the next slide, Mike. So Dr. Kupas, which is available on EMS Gov, has a wonderful description about the utilization of lights and sirens. So it's called The Lights and Sirens Used by Emergency Medical Services, Above All, Do No Harm, which really is trying to raise the question that I'm proposing over the last 5 slides, which is just simply to address this overall behavior of lights and sirens utilization in the same way the approach should be to any other intervention that we perform, right? Is the intervention safe? Is it effective at what we're trying to deliver, right? And so you can go to the next slide, Mike. So what we're suggesting is that the approach that we are applying to this intervention should be the same as we approach to any other intervention in the EMS field. This is no different than glucagon administration. This should be no different than the conversations about drug utilization, right? So CDC is, I believe, or FDA is meeting to talk about Johnson & Johnson, right? They look at all the data, they make a determination on safety and efficacy. We're trying to recommend that we approach lights and siren utilization in the same way. And so the goal for this performance improvement project, for the most part, is to try to address that maybe we are overutilizing this intervention across the board. Maybe there is some benefit in small cases, but across the board, we found that the numbers that we presented in NEMSIS represent an overutilization of this intervention, where we've already shown that the overall benefit seems to be relatively limited given the reduction in time that we described. And so the purpose of the rest of today is to talk about how we're going to structure these types of programs to address this very topic. Our hope is that we picked a very selective audience because you all have already committed to joining. So hopefully you already find this topic very emotionally significant for your all agencies. But that's at least a little bit of the background of why we've chosen this project and what we're hoping to do with it. You go to the next slide, Mike.
So great, thank you, thanks, Joey. And I am kind of the interim speaker here between Dr. Grover's wonderful presentation of the evidence and Mike Tegman's vision of what's actually going to happen during this quality improvement project. I'm going to give a little bit of a context of why now, and I think there are many factors that are coming together around the country in our thinking about the practice of EMS and in the tools that are available to us. And this is it's an opportune time to really take something that, as Dr. Grover has said, is definitely a safety issue in EMS and do something about it. So if you go to the next slide, Mike. The EMS Agenda 2050 really painted a picture that I think we can all agree with, that there are definitely features of EMS of 2050 that we want to make a reality. And the one that we're going to focus on with this is really talking about safety and efficacy. And there's we have to keep in mind the other elements of the agenda, but this is a goal. We're trying to achieve safety and efficacy with this project here. And I think that we very much view this project in line with kind of the vision and future of EMS. And if you go to the next slide. And so at the National EMS Quality Alliance, we built on a lot of work that's been done in the past, both with the EMS Compass effort and really prior to that, with almost a decade or two of evidence related to certain specific clinical and operational measures that impact patient care. And when we were thinking about this project, again, I think, as Dr. Grover said, we really wanted to highlight something that applies to all EMS agencies across the country. And Safety 01 and Safety 02 are two of the very important the National EMS quality measures that we're going to focus on with this project. And I think as part of the NEMSCO leadership, we've very much focused on trying to make all of these measures practical and usable for EMS agencies across the country. And this project is really building on that work as well, where we taking these measures and putting them into a true quality improvement project. And so this is our vision, right? And here we are today doing exactly what we hope to accomplish, right? So we're convening a sustainable, I should say this is the first step in convening this group, but convening a sustainable national collaborative of associations, organizations, and individuals to come together on a quality project and measurably decrease the use of lights and sirens during EMS response and transport, right? Because we think it's the safest thing to do for our patients and for our colleagues. And we're essentially promoting a people-centered EMS system, a culture of safety and of quality improvement while we go through the steps of improving this work. And so hopefully what this will do, and we hope it will be a foundation for future efforts in quality improvement, be it with cardiac care, with stroke care, with whatever the specific clinical condition might be. But at the end of the day, our goal is to save lives in the EMS setting, and really provide a model for what can be done to improve care across the country. So, without further ado, I'll turn it over to Mike Tegman, who is our improvement advisor in life and in all things EMS, and he's going to really take us through the meat of what we're going to be doing today. So thanks, Mike. Appreciate it.
Thank you, Doctor. It's exciting to be here with everybody. I would invite you while you're listening here, open up the chat and just introduce yourselves. Say hi to folks. The chat's open if you want to cross chat with your friends. And any comments, questions, quips, quotes, small speeches, anything that you're inspired to do, toss them into the chat, and you're welcome to interrupt me at any point in time. The framework that we are using to facilitate this collaborative comes from the Institute for Healthcare Improvement. This is their Breakthrough Series collaborative model that was created about 21 years ago now, and it was basically their concept to bring improvement science to scale and to spread it. So it basically focuses on taking things that we know make a difference, where improvements have actually been made in selected places, and bringing them to a large scale and spreading them across the country or across the world. And one of the challenges is to help people understand that this is not research science. This is improvement science. So the research is done previous to this. This is about implementing it and deploying it across the country so that most places get the benefit of whatever the best practices and knowledge happen to be. So Lights and Sirens is our project. The next step in this model for breakthroughs is to identify topic experts, folks who have made successful improvements, and people who are expert in this work. And we've got several of them here with us today. At Dr. Brian Wilson, who's you'll see some of his work here shortly. Dr. Jeff Jarvis, who's done some fabulous work in this area. Dr. John Kramer, who leads us in many things across the country and has been passionate about this topic for a long time. We've got Dr. Kupas, we've got Dr. Jeff Clausen from the International Academy of Emergency Dispatch, which plays a key component in this work. We've got Rick Farron from Niagara EMS, one of our emotional support Canadians, who has shown us that this work is definitely doable to a massive degree, and has been a fabulous thinker in this entire project. And we've pulled our expert faculty together, and we've held sessions to create a change package, which is really a list of specific actions that individual EMS systems can apply on a local or regional level to be able to safely and effectively reduce the use of lights and sirens for response and transport. And we are putting the final touches on that package together next week and at the beginning of January, and we'll be having it ready for our first learning session, which will happen in February. So the next step in the process is to enroll 30 to 50 EMS systems, and many of you have signed up. We actually had over 100 EMS systems express interest in the project. And our limiting factor is going to be seats in our software system for coordinating this. But we'll share the information and updates widely, so that even if you're not necessarily a core participant in this project, you'll be able to follow along and learn as we go. And then we'll bring you together and invite you to learn the Institute for Healthcare Improvement's approach to making improvements. So we'll teach you the model for improvement, PDSA cycles, and the change package. So just to give you a little bit of a sneak preview of that education for those of you who haven't been exposed to it. This is the model for improvement. It was actually created by the Associates in Process Improvement in Austin, Texas. They've given us permission to use it as part of our project here. And it starts with three simple questions. The first is, what are we trying to accomplish? And for this project, it's really simple and straightforward. Reduce the use of lights and siren for 911 call response to 30% or less, and the use of lights and siren for transport to 5% or less across the country. And we've talked with EMS systems, the variation in the percentage of response and transport use of lights and siren is staggering. There are some systems in the country that are less than 5% today. There's one system I talked to that transports 81% of their patients, lights and sirens. So the variation is pretty dramatic. The next question is how we know that changes in improvement. This goes to your measures, and thanks to NEMSQA, we have the safety measure 01 and 02, which line directly up to our aim. And what will be one of the things we'll be asking of you as participants is to share your performance data on a weekly basis through the duration of this project. So we'll basically be looking for 4 numbers each week. The number of 911 calls you ran during the week, the number of those that were responded to with red light and siren, the number that were of transports related to 911 calls that you had during that week, and the number of those transports that were transported utilizing red lights and siren. The next part of the model for improvement of what changes can we make that will result in improvement. These are our working theories, if you will, about what we think will result in improvement. And this will come to you in the form of the change package. And then the plan, do, study, act cycle. This is the basically doing small tests of change. And this is the work that we're going to ask you to do in your systems during the space after the first learning session, where you will test and then share your learning about what you learned during each of your PDSA cycles, and we'll give you a lot more detail about how those will work for you. And then once you've practiced and worked with these for about 5 months, we're going to hold a second learning session where we're going to summarize. We'll use a little bit of qualitative data analysis and quantitative data analysis to really see what have we learned together as a group. This is in the spirit of kind of all teach, all learn together, which is something IHI President Maureen Bizigano, when she was president, used to say frequently. If we all teach and all learn together, we'll make much better progress faster. After that next learning session, where we kind of refine our tests, we'll go back out and do another round of testing and sharing and learning for another 3 months. And I want to kind of give you a visual, and this comes, thank you, Dr. Wilson, for being able to share your work. Brian worked on this project as part of his NAMSP quality and safety course work, and he shows that you can pretty dramatically reduce it. So this is with him and his colleagues in Bethlehem, Pennsylvania. The y-axis on this scale is 0 to 50%. So you can see they started with a lights and siren response level that was lower than many places in the country for their 911 calls. But they have dropped it down, and he updated the data as of last week for us to 25%. So they've been able to cut their response lights and siren use in half. Their transport lights and sirens started out just a little bit north of 6%. And you can see that they have got it down to under 2% reliably. So part of what we're going to offer to you is we will collect your data, and we will produce run charts and control charts for you of your own performance, and share them with you, and we'll share them with everybody else. And then kind of at the end of this, we'll come together.
Mike, I'm sorry, can I interrupt for just one moment? I just
don't want people
I don't want people to be intimidated by the fact of Brian's the Bethlehem EMS data. I mean, if you go back to it, it's amazing. And not everybody has to, one, start off like that. And two, this is something we talk about. We got to set our own goals. We have to make sure that it makes sense for your agency and your organization. We look at this, and we all of us kind of have our jaws dropping in many ways. So just, it looks great, and we'll all get there, but it may be a little intimidating just to even think about where he's starting.
And I appreciate you sharing that. Just personally, I'm inspired more than intimidated, but I'm not running an EMS system these days, so I get to be inspired rather than intimidated by hard work. So thank you for that perspective. I agree with you. So then we'll come together and we will craft and then publish a final change package. And there's a peer review framework for publishing improvement science work called the Squire Guidelines that we will use to put together a paper that we will submit for peer review publication as a result of this. So just real quick, before I go on to kind of what your benefits are and the timeline for participating in this, questions, comments, anything else from our expert faculty or anybody else on here? You can, just raise your hand or unmute yourself or type into the chat. So Brad Kramer just typed into the chat. It feels similar to sea change and spinal motion restriction from just do it to everyone. If there's a hint, it may help because it doesn't hurt, to understanding that full C-spine and significant risks and downsides, and working to use it judiciously with a clear benefit in mind. That's a great analogy. I agree with that. And Rick said the greater the percentage of licensed Siren use now, the greater the opportunity for improvement, which should help with the intimidation stuff. I appreciate that, Rick. Anybody else got anything else they want to jump in on before we move on to benefits here? I'm a grad school professor, so I can do long rounds of silence if necessary. All right, we'll slide on here. So the benefits to each of your systems for participating in this, the obvious one at the top of the list is it really improves safety for your providers, your patients, other drivers and pedestrians in your community. And I don't know how many of you subscribe to any of the listservs or the ems1.com or those kinds of things, but the number of ambulance involved crashes, and maybe it's because since we started this project, my eye has been attuned to them, but they feel like they're through the roof. And so getting improved safety for your folks is obviously the most important one. You'll also get some free improvement science education that in many other circumstances you'd have to pay for. A fabulous opportunity to network with some amazing people. I wish I could call out the names of all my friends here I see on the list so far, but this is a cool group to be part of. You'll learn the evidence-based quality improvement techniques. You'll learn the change ideas and improvement strategies from your call as we go along in our live learning sessions. Any system that needs it, one-on-one coaching will be available from a number of us who are pretty improvement science steeped and focused. I just got that little signal that said my internet is unstable, and what my computer doesn't know is it's not the only thing unstable in this world. And lastly, you'll get credit as a participant in the first ever really national improvement EMS collaborative, which is kind of a big deal. And you'll be credited as a contributor to the final published change package and peer review paper. So what we're going to ask of you is to participate in our learning sessions when they're scheduled, and we'll have the first one here. We'll show the timeline here in a second. Share your performance data with us on a weekly basis. Implement some or all of the change package. Your circumstances vary widely. That phrase, if you've seen one EMS system, you've seen one EMS system, is true, and your local politics and your relationships and your workforce and your protocols and all those kinds of things are different. So you'll need to adapt the package to your own local circumstances, but we'll want you to try some of the change ideas, and if you come up with others that we do not have in our change package, we'll want to gather those from you and build it into the refined change package in our second learning management system. And as you are learning things, we'll want you to share those, your PDSA cycles, with the larger group. So here's our timeline. We began this work in at the beginning of last year, and in this next coming year, we're going to start with getting some data collections and review and refine our change package. On the bottom of the project timeline here, our first learning session is February 3rd. And please put that on your calendars and block out that time if you don't have it down already. And then from that February meeting through June will be the first action period of doing and trying PDSA cycles and trying to move your own dots on your own run chart and control chart. Then in later in June, we'll bring you all together for our second learning session, another action period from July to September, the third learning session in September, last action period, and then the last one in December, which will really be bringing together and kind of gathering all the data and information for the final recommendation and package. And then in January, we're probably going to have a summative Congress where we congratulate each other, share the final change package. We're exploring the possibility of doing that as part of the NAMSP conference next year. So with that, I will open it up for questions, comments, quips, quotes, anything from anybody here.
You know, and I think part of the discussion should be, right, it's kind of a check-in with yourself about, you know, this is, you know, it's a bit of a commitment. We're going to talk about the details in just a moment, but, you know, ask questions that would, you know, like help shape the way that you would approach this. Because we want it to be meaningful, and it involves a bit of time, but we think that the effort is worth it.
So the question is, will this presentation be emailed out to participants? I think we can make that happen. Sheree, am I right about that?
Yeah, we'll post the recording and share the slides as well on the NEM School website.
So the next question from Brian is, with so many agencies and systems looking to participate, how will they be chosen? So we're kind of doing a first come, first serve based on the ones that signed up. And we'll have a waiting list because we anticipate that some of the folks who initially signed up may realize that gathering this data is harder than they thought. You know, it's interesting when you start actually looking into pulling this out, looking at CAD systems and electronic medical record systems. Many systems don't capture their lights and siren use, which is, if you don't have access to the data, it's hard to participate. So we'll have a group that's the core group that's in and a waiting list. We're gonna ask you to make a commitment that you're all the way in here after this session, and basically let Sheree know, who is our project manager and the executive director of NEMSPA here on the call with us, that you're fully in, but otherwise it'll be a waiting list, and we're still working out kind of how to invent keeping everybody on the waiting list involved and updated as much as we can, but that's pretty much the answer to this question. So Mike said, how to into this 100%, how do I sign my agency up, or is it already set up? I think our survey is pretty much closed at this time, but Mike, if you want to, I'll put my email in here, and if you want to chat about it or explore ways to be involved, happy to chat with you. Let's see, wondering if interfacility transport program will limit my contribution to the project. very interested in participating, but not responding to 911 calls. So for this project, Omri, I think you probably might want to step back and pay attention and not take up one of the frontline seats if you're not running 911 calls. And then Matt Zavatsky's got his hand up. I'm looking at the chat and not looking at the screen, and he jumped in the chat to show me that his hand is raised on the screen, which is really advanced Zooming strategy here. Matt, please jump in.
Mike, it's all about meeting the person where they are, right? You taught me that. So if you're in the chat, I'll meet you in the chat. Don't look at the screen. We're good to go. Just wanted to let everybody know, for the last year, off and on, because we took a COVID break, much like everything else, about 8 national EMS associations and patient safety organizations have developed a joint position statement. And we are now, thanks to Dr. Kupis, and I know that Dr. Wilson's on that group, and a number of folks that are on this meeting as well, we are now about 30 to 45 days away from having a final, very collaborative joint position statement from really the whole alphabet soup of national EMS associations, encouraging the industry to do everything possible to reduce light and siren vehicle operations. A, it's a great articulation of a joint belief. B, the fact that we have so many associations that have helped author that 1.5-page position statement is a testament to the gravity of this issue. So be looking for that. Where the process is right now is it's officially the authors of all of the representatives from all of the associations have taken the final draft, are running it through their boards and committees and all that sort of stuff for final endorsement, so that it can be released shortly after the first of the year as sort of a happy holiday gift to the rest of the EMS community. And I want to thank the people that have been part of that process. Again, many of you who are on this meeting, including Dr. Kupis, Dr. Wilson, a number of others, for really pushing that forward. And it will help this program, this process, I think, very substantially. So
thank you for that, Matt. And we've been eagerly anticipating the release of that document. My request is for you to push your approvals through so that we can include it in our change package for our meeting in February. What else? Anything else from anybody else? Let's see here. So Klaus put in the chat, I have not heard any discussion about the obvious benefit to crews on reducing stress. Boy cries wolf scenario happens every time a crew responds to an alpha call code 3, extra adrenaline. There's nowhere to go, huge health implications. So that's an interesting point. And I think it's definitely worth exploring. There is a flip side of some crews who have been running red lights and siren for a long time and don't feel stressed by it, may feel stressed by being asked to not use lights and siren as often as they do. But certainly, and Dr. Kramer and I just got off a call that his team at NHTSA hosted around stress management and mental health for EMS across the country. So I clearly workforce perceptions, workforce stress, community perceptions, community stress, co-responder perceptions, co-responder stress, system dynamics, they all fit into this. It sounds easy just to, hey, we're just going to quit using lights and siren on a bunch of these calls that don't need it, but there are cascading implications depending on your community that all fit into this. So thank you. Will we publish the list of agencies that are participating? I believe we will. Does that sound right, Sheree?
I look to you as the change package expert, but yes, I believe that is our plan, is that they will all receive a mention in the change package for your efforts.
Absolutely. Great. Any other questions? Any other thoughts? So can I just see your hands if you're all in on this? You can just put your little hands up on your screen, or raise your hand if you're on screen, or thumbs up, something like that. There we go. I like seeing that. So next steps. Contact Cherie Murphy. Here is her email address to confirm your participation status. You should also all have that already.
Hey, Mike, do you want me to take this one as the
Yeah, and then it looks like
of the group?
That'd be great.
I know there were a lot of questions regarding participation and how do you get in and are you in? So I'll just take a quick step back. As Mike said, we had overwhelming response to our call for participation in this project, and unfortunately have to limit to 50. And I think that's for the good of the project and the participants, that we don't dilute the efforts. But as Mike said, we'll figure out a way to be able to include those in receiving the information, so on and so forth, for those who don't make it into the official 50. As he said, it was first come, first serve on signups to the survey that was put out. So this week, we did send out an email that said either welcome to the collaborative or you are on a waiting list. So if you enrolled in that initial survey to express your desire to participate, you should have received one of those two emails that would let you know what your status was, whether you are in the first 50 or whether you are on a waiting list. We don't want to ask you to fill out another commitment form. Some of you have already responded to that email saying you're in, but if you could just, the email would have come from me, so it would be smurphy@nemsqua.org. So if you would be so kind as to, if you have that email saying welcome, that you are in, if you would be so kind as to respond just to say really quickly, confirm our participation after hearing the expectations. And if not confirming, just to let us know that you're unable to meet those expectations so that we can offer the spot to somebody on the waiting list. So if you're on the waiting list, there is hope that you might get in. And if you did not receive that email from me and you're unsure your status, obviously you can just email me and ask me your status and I will let you know. Like Mike said, our first learning session will be February 3rd. We will send a calendar notice to the confirmed participants at this point. And we will also send calendar notices for the subsequent learning sessions that we have scheduled, so you can have those on your calendar. I apologize for all the Outlook dinging that you might hear as you are all furiously emailing me. And then the last next step would be to just start thinking about your implementation at your system or agency. Think about the team members that you'll need to involve. Think about, where you're going to get this data from, and so that you are ready come February to jump right in and know, baseline where you stand and what efforts you might undertake. So we will also be, as Mike said, we're finalizing the change package. So we'll get that out to you prior to that first learning session. And Joey, Mike, or Michael, if I have missed anything, please let me know or jump in and add to it.
I just want to make sure that there's no confusion. If you don't hear back from somebody, by when are they pulled off the participant list and somebody else slid in?
I will, if I do not hear from you, I will proactively reach out before we pull you off. Once you get the email that you are off the wait list, let's say you got the wait list email and I send you an email saying, hey, a spot opens up, do you want it? We'll give 2 days for folks to respond to that. I understand over the holidays, we may need to extend that, but maybe we'll say come January, we'll start adding people to the wait list after the holidays, and give folks 2 days to respond to that, because we do want to make sure that we give folks time to prepare, to be involved in February and do whatever ground, legwork they need to do to be prepared.
That sounds great. I do see, I see a couple of people who just recently raised their hands. So if you want to jump in, just unmute yourself and chat. Or are these just all in hands?
These are excited hands.
These are excited hands. We like all in hands. Great. I don't have anything else for today. Michael, Joey, Cherie, anything else?
No, I just thanks everybody for such an enthusiastic response, and I'm just looking forward to moving forward with the project and seeing what difference we can make.
That sounds wonderful. Wonderful. Well, I hope you all have safe and Omicron-free holidays, and we will see you at our first learning session in February. Thank you all.
Thanks, everyone.
Thanks, Mike.